Good day, colleagues. It is with great pleasure I would like to discuss the most relevant but yet neglected issue, which is the mental health well-being within the medical workforce. And I would like to dedicate this video and my presentation to the medical workforce within my health district, which is the Illawarra and Shoalhaven local health district hospitals, located within the Wollongong and Shoalhaven area in the state of New South Wales, Australia. First of all, I would like to pay my respect to the traditional landowners of the district, the Darawal and In community of the past, present, and emerging, and also to my executive board to have given me the opportunity to work as a medical co-director for population and public health for the district. I'm also very thankful to my Department of Rehabilitation, where I work as a senior staff specialist in rehabilitation medicine and brain injury medicine, and to my medical, nursing, allied health, administrative colleagues who works within the medical workforce across the district. And would like to dedicate my presentation to my colleagues in order to acknowledge the issue, understand, and recognize the problem, and to solve as a team coming together with respect, dignity, mindfulness, awareness, and in the best interest of one's self-health and better patient care and outcomes for our district. Here again, my colleagues, I would like to present this video on the mental health issues within the medical workforce in our district and how best we can identify the key policy initiatives, directives, and implementation, and finally live as an example to recognize, deal with it, and seek appropriate therapeutic regimes and recommendations in order to look after oneself and also our patients. Thank you once again for listening to me, and I hope you enjoy this educational video to come.
Oh, perfect. Another day in the medical workforce. Right before I have to face the challenges of mental health. Amazing. Tried everything. Self-care routines, therapy, even mindfulness apps. Spoiler, none of it worked. Then I found support from my colleagues. I was skeptical but also desperate, so here we are. We lean on each other, share our struggles, and boom! Feel a little less alone in this fight. If you're in the medical field and feeling overwhelmed, trust me, you need this support. Reach out, connect, and thank me later.
Exploring mental health issues within the medical workforce in the Illawarra and Shoalhaven local health district is crucial. Recent policy initiatives aim to address these challenges, focusing on support and resources for staff. Key recommendations include enhancing mental health training, increasing access to counselling, and fostering a supportive work environment. In conclusion, prioritising mental health in our hospitals not only benefits staff, but ultimately improves patient care.
Good day, ladies and gentlemen. I would like to discuss my presentation on exploring mental health issues within the medical workforce at the Illawarra and Shoalhaven local health district hospitals. I take this opportunity to acknowledge the traditional landowners of the district, the Dharawal and Inn community of the past, present and emerging. And secondly, to the executive board of the Illawarra and Shoalhaven local health district hospital, and to the medical staff, nursing, allied health clinicians, and above all, to my patients of the district. The mental health and well-being of the healthcare workers has been on the agenda for many years across various districts in our state of New South Wales, Australia. In particular, we have seen emerging trends in mental health issues within the medical workforce, especially post the COVID pandemic. There has been emerging trends of significant burnout, anxiety and depression amongst the medical workforce due to significant workload issues, fatigue, long hours, and many other factors. The District Health Directive 2022 to 2032 acknowledges these significant challenges and outlines key health directives and policies to address these issues. I have taken this opportunity to highlight some specific issues within the medical workforce and target the specific policies, initiatives, and directives, and recommend some implementation strategies moving forward for better outcome for our doctors, nurses, and allied health workers and administrative staffs, and above all, for better patient outcome and care. The burden of mental health issues within the medical workforce not only affects a specific individual, but also impacts on the team dynamics, patient care and safety, workforce retention. In particular, I would like to highlight the Southeastern New South Wales lived experience work framework, which was developed collaboratively by the ISLHD and regional partners, offers a promising model for integrating peer support and lived experience into the workforce well-being strategies. The Code of Practice for Managing Psychosocial Hazards at Work, developed under the New South Wales Work Health and Safety Act 2011, mandates that employers take reasonable steps to mitigate psychological risks within the workforce. We at ISLHD do have geographical diversity in the district, from urban centers like Wollongong hospitals across to the rural communities in Shoalhaven. And although this particular model has an advantage, creates disparities within the equity and access along the mental health support, staff support, and disparity within the infrastructure that contributes to significant issues of resources. Despite these challenges, several opportunities do exist regarding policy development and implementation. So what I have seen is that we do have a great model of care based on lived experience workforce framework collaborated by ISLHD with their regional partners, along with implementing the digital mental health framework. But the challenge was the availability of the interventions and the resources and access that posed a significant challenge. We also see that workforce culture is quite dynamic, which poses a significant challenge for implementation. So here I would like to highlight the 5 proposed policies that we can delve into and see how we can best discuss and implement it. The first one is the mandatory mental health training, which was established to assess and monitor the well-being within the medical workforce. Secondly, the peer support integration program. Third one is the flexible access models incorporating digital health solutions and telehealth services. And the fourth policy drive is the leadership accountability. And the final one being the workforce redesign based on the above policies. So what I decided to do is to do a stakeholder influence and generate an interest matrix. And the matrix categorizes the key stakeholder groups based on the level of influence, what I call them as critical enablers for policy initiatives and development. The key insights on policy development were based on a high influence, high interest group involving the executive administrative group, medical doctors who were actively involved in decision making and implementation. The second group were the high interest, moderate influence group involving the nursing staff, allied health staff, and patient advocacy group. The third critical enablers were moderate influence and interest group involving the mental health NGOs, local council, and community members. And the last critical enabler group involved a low influence but high interest group, which were again the advocacy on public trust, so in this slide, as it appears to be very academic on the stakeholder influence versus interest matrix, I thought I will give you the opportunity to read through this slide and get some insight on the key stakeholder influence and their impact on policy development. Here I have highlighted the importance of equity in mental health care, given the disparity in the access between the urban and the regional areas, and how key policies can be developed to address this gap. So any policy development should be evidence-based, trauma-informed care, along with appropriate framework design that incorporate a holistic biopsychosocial model in order to address the disparities within the healthcare policies in mental health. So you will see that this has been highlighted in this slide, and I would be pleased if you could spend some time reading through this slide and getting some insight. So to summarize, in order for a sustainable health policy, we need appropriate funding sources, which should be identified and leveraged. So I have outlined the potential funding sources, which includes the New South Wales Workforce Wellbeing Grants. Secondly, the Commonwealth Mental Health and Suicide Prevention Programs. Thirdly, partnership with NGOs and primary healthcare networks. And local government and community health initiatives, grants for culturally inclusive and tailored to outreach mental health programs. So in order for a sustainable policy that needs to be evidence-based, well-resourced with appropriate funding, and should incorporate an integrated biopsychosocial model, and it should be well aligned within the core values of the district. Trauma-informed initiative, which should also be inclusive, culturally appropriate, and should have an integration of BHDIS and class standards with a well-designed program that can be quite resilient and sustained through any dynamic turbulence that may occur over the years. It is also important to acknowledge and recognize the key challenges and the barriers for policy implementation. I call them as critical disablers, which has to be addressed, identified, and rectified. One of them is the stigma that is surrounding the mental health, the community perception, the perception within the medical workforce can be a significant barrier. The second barrier I see within the district is the access, equity, and poor cultural inclusions, financial restriction, and systemic failure within the organizational structure. And the third barrier I see is a lack of validation in access across geographical location due to inability to perceive the need for remote and regional areas. Additionally, I would like to highlight the fact that an organization should be ready for change. The change process starts from within, and it should be global across the organization for readiness to change. Secondly, in spite of having adequate financial resources and grants, we need to have the right people doing the right thing and identifying the key drivers with regards to policy initiatives and directives are immensely important to deliver the right key initiatives at the right time. And finally, the policies, as previously mentioned, should be trauma-informed design with a forward-looking policies with incorporating an integrated model with a cohesive approach is required. The other challenge and barrier I have highlighted here is the data access and limitations, which may hinder the ability to monitor and effectively evaluate the policies. Whilst the BHDIS provides a framework for data collection, gaps in reporting, and inconsistent metrics, and privacy concerns can complicate efforts to track the outcomes and identify disparities. So, in summary, even if the proposed policy offers a visionary and inclusive approach to workforce mental health, the success will depend on addressing these challenges head-on with the key strategic planning, stakeholder engagement, with an adaptive leadership, and crucially navigating these limitations to ensure a meaningful and a lasting impact of the policies and development. So here I have highlighted what is needed. As I previously said, any change needs to start from self and within. In my role as a medical co-director of the Population and Public Health within the Illawarra and Shoalhaven local health district hospitals, what I intend and plan to do is to have a 360 degrees feedback for a self-management and a professional development plan to identify what is required, what needs to change, what are the existing issues, what do we do best at this point in time with regards to this key policy, and what is the proposed change that is required. The second step is to collect all the relevant data and feedback mechanisms with regards to how I can process as a leader in order to successfully implement the policies and navigate through this process. Thirdly, to establish a clear channel of clinical engagement with key stakeholders and have their buy-in as much as possible, and play a crucial role for a communication link between the hospital executive group and the existing clinicians. The next step I would like to do is to develop a Gantt chart work plan for a period of 12 to 24 months and stepwise write down a clear plan of management for appropriate analysis and execution. And finally, to have a constant engagement within the organization and key stakeholders, community, for policy development and implementation. So here, following the initial preparation planning, I have outlined the implementation stages of identifying any challenges and barriers and addressing them, and setting up a working committee for periodic meetings and addressing any issues, and developing a blueprint for a rollout plan, and then rolling out for a period of 12 months to see what's the impact over the 12-month period, and then finally establishing and implementing the policies. So in conclusion, the mental health framework policy design is dynamic and ever-changing. In a dynamic medical workforce world that we live in, and this requires a careful planning and execution with involving key strategic people, right from the administrative to medical workforce, and appropriate consultations with key stakeholders, and regular participation and developing policies with incorporating and analyzing better health data and information standards, and culturally and linguistic appropriate services standards. And the policy requires a broader outlook for sustainability, resilience, adaptability, and addressing equity, access, support across the board, and based on trauma-informed design. And overall should uplift the outcome of the target population that it is designed for, and help with patient outcome and care. Not only does the key policies requires appropriate designing and planning, but it should also address the health inequalities within the society, and address the appropriate challenges and limitations, and target sustainable funding resources to remain sustainable even if there is a financial crisis that could occur over the years in the health district. In my final conclusion note, I say that the policy is just more than just an intervention. It should be from your heart, but logically based, evidence driven, with sustainable resources, involving the right people doing the right thing, for the right thing, and address the targeted population in order to bring the best policy outcomes, standards, and address the equity, inequality, access, and overall to provide the best possible integrated policy for healthcare, not only for the medical workforce, but also for the population in the district. I take this opportunity to thank you all for listening to my slides, and I hope that I have done justice to your listening time. Bye for now. best wishes to all of you in your career and development and in your personal life.